Perfect. So hello everyone, good morning, good afternoon for wherever you're joining us from. So my name is Marina, I'm the webinar coordinator for Evidence Synthesis Ireland, and we're delighted to welcome you all to our summer webinar series for ESI. So just by way of brief introduction, for those of you who may not know much about us, Evidence Synthesis Ireland, ESI, includes Cochrane Ireland and is an all-Ireland initiative funded by the Health Research Board and the Research and Development Division of the Public Health Agency in Northern Ireland. Our aim is to build evidence synthesis knowledge, awareness and capacity on the island of Ireland. We have a number of key activities for achieving that aim, and one of them is a monthly webinar on an evidence synthesis topic. Our presenter for today, who we are absolutely delighted to have, is Dr. Andrea Tricco, who is on the line, but I will just briefly introduce her first. So Dr. Andrea Tricco is a scientist and director of the Knowledge Synthesis team in the Knowledge Translation Program, Shing Knowledge Institute of St. Michael's Hospital in Toronto. She is an associate professor of the University of Toronto in the Dalla Lana School of Public Health, Institute of Health Policy, Management and Evaluation. She is also co-director, adjunct associate professor for the Queen's Collaboration for Healthcare Quality Joanna Briggs Institute Centre for Excellence at Queen's University. Her research program focuses on advancing the science of knowledge synthesis and responding to information needs of decision makers. So today's webinar will be discussing rapid reviews. So the learning objectives of the webinar include defining rapid reviews, differentiating between rapid reviews and systematic reviews, identifying how to conduct rapid reviews, and establishing how to tailor rapid review methods according to decision makers' information needs. So Andrea will present, and then we'll have time for questions and answers at the end. So we encourage you to type your questions in the Q&A box. Hopefully you can see that down at the bottom. As you go along, please feel free to ask your questions. And we will make a recording of this presentation available on the website afterwards. So I think that's all from me. Andrea, I might let you take it away there. We're really excited, and thank you so much for joining us today.
Great, thank you so much, Marina. It's my privilege and honor to be here today with everyone speaking about a topic that is very close to my heart. I want to begin by thanking Evidence Synthesis Ireland for the invitation. So in particular, Declan, Nikita, and Marina for all of your help and support leading up to this. So really appreciate it. In terms of my journey in rapid reviews, this actually began in 2010 when I was commissioned to do my first rapid review. I experienced quite a lot of turmoil doing my first rapid review because, I was trained as a Cochrane collaboration systematic reviewer. We did things very methodologically in a very systematic manner. And now it was this uncharted territory of the rapid review where I was being asked to take some shortcuts and produce results very quickly. So I have to admit that it did create a real sense of discomfort. I may have cried, and it was a very challenging time for me. And this actually led to my wanting to advance the methods and the science in rapid reviews. So I'm quite passionate about this. So I'd like to acknowledge the traditional land on which my research team operates in Toronto, Ontario, Canada. We are incredibly grateful to have the opportunity to work on this land. I have no conflicts of interest to declare other than having a real passion for rapid reviews. And as I mentioned, a lot of personal experience in this area and really wanting to advance the science of rapid reviews. Today, we're going to cover some of my methodological work on rapid reviews over the last 7-8 years, as well as how to conduct rapid reviews. We're going to go through how to tailor your rapid review to knowledge user needs, discuss a little bit about rapid reviews that happened during the novel coronavirus 2019 or COVID-19 pandemic, as well as describe other important work on rapid reviews. So there's been a lot of work being done internationally, and I have been working in rapid reviews for quite some time now, and wish to acknowledge a lot of my colleagues and give a shout out to many of my colleagues who have also been working on very important projects in research and furthering the science of rapid reviews. So I will be giving some shout outs to some colleagues and describing some other important work that I would encourage everyone to become familiar with. So I think we will pause here just for a quick poll to see what is your experience with rapid reviews. So Marina, maybe I'll hand it to you to open that poll. So we're gonna do, thank you. Sorry, Marina, go ahead.
No, that's perfect. Thank you. I've just launched that. So if everyone can vote on the first poll, please. Thanks, Andrea.
Great, thank you. Yeah, so this will just kind of give me an idea of where everyone is coming from. So if you could let us know, what is your experience with rapid reviews? So I'm not sure, Marina, if we're able to show the results.
Yep, so perhaps I could call them out live if that's easier.
That would be great.
Thank you, everyone. We've got almost 150 people have voted so far. So we've about 55% are new to rapid reviews. Let's see, just under 30% have limited experience with rapid reviews, and 16% have conducted rapid reviews, and about 2% are experts in rapid reviews.
Okay, excellent. That's great. So that's really wonderful for me to see, you know, where everyone is at. And for those that are new to rapid reviews, not to worry. You know, I've tried to keep the presentation very simple, and hopefully you'll be able to gain some new knowledge in this area. And for those of you who are experts, please bear with me. Hopefully there's one thing here that I present today that might be new to you. So thank you so much, Marina, for that poll. When we think about a systematic review, the definition that's most commonly used is the one put forth by the Cochrane collaboration. So this is the explicit and systematic method to identify, select, critically appraise, and extract and analyze data from relevant research. So when we're thinking about a systematic review, the focus really is on accuracy and comprehensiveness and trying to reduce the bias associated with the findings. So we're following methods very systematically and making sure everything that we do is to decrease bias. In general, this is based on research. So empirical evidence suggests that in general, a systematic review takes around 12 months or longer to complete. And I'm in Canada, so we usually think of it in terms of about $100,000 Canadian to do a systematic review. Excuse me. In contrast, a rapid review is a type of knowledge synthesis that accelerates the process of conducting a systematic review. This is done through streamlining or omitting specific methods to produce evidence for stakeholders in a resource-efficient manner. So this is the definition that has been posted on the Cochrane Rapid Review group. The reason that I've used this definition, there are many definitions out there on rapid reviews, is that I feel that this is a real advancement to the science of rapid reviews. And this is part of a paper that will be coming out in the Journal of Clinical Epidemiology, hopefully in the next couple of months. So would highly encourage everyone to look out for this paper. This definition is great because in here, they talk about the traditional systematic review. So that would be like what we said with Cochrane, where we're screening, we're critically appraising, we're extracting, we're analyzing data. So all of these steps. However, when we think about a rapid review, either we're streamlining or we might actually be omitting specific steps. So I thought that was quite great that the authors of this definition bring this up. They also bring up the notion of a stakeholder. I refer to these individuals as knowledge users in my presentation, and I'll have a slide on this in a couple of moments. So I love that the focus is to produce evidence for stakeholders. So oftentimes when we're doing a rapid review, it is to help with decision making. They also talk a little bit about resource efficiency. So this could be in terms of time and in terms of money as examples. So indeed, when we look at a rapid review, and again, this is based on empirical work, on average, it's about 5 to 12 weeks to complete. and on average around $25,000 Canadian. And so when we think about a rapid review, the focus really is on timeliness and making sure we have those results in the hands of our decision makers just in time for their decision making. So when we think about the review process and rapid reviews, there's actually not one method that we have all universally agreed upon. So this is quite interesting because it really depends on the topic and the question. And so this is what we're going to get into a little bit later in the presentation today. A variety of different methods can be used to streamline or omit specific steps of the systematic review process to produce results rapidly for our knowledge users. However, no matter what we do, what we conduct must be produced in a transparent, scientific, and reproducible manner. So we want to be very thoughtful about the steps that we take and the methods that we use in our rapid reviews. And as a rapid reviewer or the knowledge producer, so the individual or the team who have been commissioned to do this rapid review, we need to be in constant communication with our knowledge user. And when we think about knowledge users, we have three main buckets. We have our patients or citizens, we have healthcare providers, and we have policymakers. We want to make sure that our rapid review is addressing their needs. That's number one importance and number one priority. And in the guide that we produced in collaboration with the World Health Organization, we explicitly state that rapid reviews are fit for purpose knowledge synthesis products. So this is why we don't have an agreed upon rapid review method, and this is why we really need to tailor our methods according to our knowledge user needs, as well as the topic that we're focused on. So when we're expediting the systematic review process, what are some factors that you need to consider? Well, you need to consider the duration or the timeliness. So when is this decision required? When do our decision makers or knowledge users need the information in time for their decision making? So that's number one, thinking about when do we need to produce these results by? Then the second thing to think about is the purpose. So what type of decision is being made? So when I'm speaking with my knowledge users, I ask them, okay, what decision are you making and when do you need this by? I also work very closely with them to manage the scope, because if they need something done in 10 days, 15 days, so in a couple weeks time, I have to make sure that the scope is focused enough so that I can give them something that I am reasonably confident will be accurate and will provide them with the information that they need. So if the scope is too broad, I might miss some really important evidence that could help them with their decision making. And we also have to be very thoughtful about the methods and how will we tailor them to make sure that we produce results that will be helpful for our knowledge users. So when we think about our knowledge users, who are these individuals? These are the people who are likely to be able to use our research results to make informed decisions about health policies, programs, and/or practices. So a few examples, as I mentioned earlier, the three main audiences that we consider when it comes to rapid reviews would be patients, policymakers, and healthcare providers. But other examples would be citizens, would be researchers, would be educators. So there are other individuals who can use our research results. And the reason we use the term knowledge users is because that's a term that we use here in Canada with our Canadian Institutes of Health Research, or our CIHR national funding body. Knowledge users are important because we are seeing an ever-increasing demand for evidence in decision-making, which is an amazing thing. So we want to be able to help respond to our decision makers or knowledge users and help them by providing them with this evidence. And when we engage and work very closely with them, it actually increases the relevance of our rapid review. And hopefully this will lead to an increase in the uptake of our rapid review results. And by this way, we'll have greater value and impact of our research. So in Canada, this has been a real focus with CIHR, and we've been trying to work towards co-creation, where we have teams of individual researchers as well as knowledge users working together to co-create research. And a rapid review would be a great example of how we could work with our knowledge users at all steps of the knowledge synthesis or rapid review process to co-create a product that is very relevant as well as useful for their decision making. So I think we can stop here for a quick poll, Marina, and I would like to hear from everyone. What is your experience working with knowledge users?
Great, thank you, Andrea. So just seeing the live results of question number 2, 45% have no experience, 40% have worked with knowledge users previously, and 16% have extensive experience working with knowledge users.
Great, thank you so much, Marina. That's fantastic. So this is great. So we have about half of us who have experience working with knowledge users, so that's fantastic. And then some of us have worked with them previously, and then a smaller proportion has no experience. So there are some things to keep in mind when we are working with knowledge users. It can take time to build the relationship. And also there's going to be a lot of back and forth, getting to know each other, making sure we're speaking the right language, making sure we're on the same page. However, it does lead to very rich research experiences, and it does help ensure that our research is more relevant. So my colleague, Dr. Lisa Hartling and colleagues produced a report in 2015 by the Agency for Healthcare Research and Quality, where they categorized different rapid evidence products. So this is a useful way to think about different types of rapid evidence products that are available out there being conducted. So the first category was an inventory. So this is where they list the evidence that's available on a given topic. So there's no attempt to appraise, summarize, or synthesize the evidence, nor is there an attempt to present any conclusions or recommendations. The other category, or the next category, is a rapid response brief. So this presents a summary of the best available evidence. It's often synthesized and contextualized in direct response to a decision maker's question. So this is actually a knowledge translation product. And the focus really, for the most part with these, is focused on pre-existing systematic reviews. So you're usually summarizing existing systematic reviews. And there can be a little bit of a continuum between inventories and rapid response briefs. So we also have times where people come up with a rapid map of the evidence that has been done, like a scoping kind of map type of thing, where they're just presenting where the evidence has been conducted globally as an example. And today the focus of my presentation really is on the rapid review. So this is where we are using abbreviated systematic review methods. So according to the new definition put forth by the Cochrane Rapid Review Group, you were thinking about streamlining or omitting specific steps to the systematic review methods. And we're modifying this to generate evidence in a short period of time. So some teams have the capacity to do a systematic review in a very quick period of time. So they could do like the full systematic review in 1 or 2 weeks. And Paul Glasziou and colleagues did publish a paper on this, talking about how they did this actually using a systematic review approach. So that is not what I'm talking about today. Today I'm talking about actually being very thoughtful and taking some shortcuts or using some streamlined methods or omitting some of the systematic review methods to produce results in a very timely way. So I'm going to highlight a few methods projects that I've been working on rapid reviews over the last 7 to 8 years. So in 2015, we published a scoping review of rapid review methods, and the focus really was to examine out there in the literature what has been done before, what guidance is available on doing a rapid review, what's the impact of rapid reviews and how are they used in decision making, and what is the comparison of results of a rapid review to a systematic review. So this was something we published in BMC Medicine, and this was kind of like a baseline, providing us with knowledge of where the literature was, where the gaps in the science were, and how could we advance the field. The next thing that we did was an international survey and modified Delphi. So this was published in 2016 in the Journal of Clinical Epidemiology. And what we wanted to know was, what were people's experiences doing rapid reviews? And what were the challenges that they had to face when doing rapid reviews? And then we followed this up with a consensus building exercise, or a modified Delphi approach. And the purpose of that was to select a rapid review approach to be tested in a prospective study, which I will describe in a few slides. We also published a retrospective comparison of rapid reviews with same topic systematic reviews. So we wanted to look at systematic reviews and rapid reviews found in the literature, and most of these were found by other methodological reviews on rapid reviews. And we wanted to see, how do the methods differ between a rapid review and a systematic review? What is the comprehensiveness, so in terms of studies included between the rapid review and systematic review? And are conclusions the same or different for rapid reviews or systematic reviews? So this was based on pre-existing literature that existed, and again, the focus was to look at rapid reviews and systematic reviews that were done on the same topic. And then this leads us to the systematic prospective assessment of rapid knowledge synthesis, or SPARC study. So this is a prospective study where we're evaluating pairs of rapid reviews and systematic reviews on the same topic. So what we do is we have a systematic review comes in that has been commissioned by a knowledge user to a particular systematic review or knowledge synthesis team. And then we have about 8 teams that are involved with this, mostly in Canada, but we do have some colleagues in Spain that are helping us with this project. And so what we would do is we would randomize another knowledge synthesis team to conduct a rapid review on the very same topic. And we would have a kind of like a simulated knowledge user panel for the rapid review, so that we can get to factors regarding usability, trustworthiness of evidence, and getting to the perspective of the knowledge user. So we're trying to compare these rapid reviews and systematic reviews with respect to their results, with respect to their step-specific process outcomes. So how much time does each step take, as an example, and then what do our knowledge users think about these products, and how usable are these products? So this again was funded by CIHR. It's been going on for a few years. It's quite a large study, and we've done more than 10 pairs. At the end of the day, we want to look at what is the reliability of conclusions as well as results when we're thinking about a rapid review compared to a systematic review. And we're also comparing the number of hours for tasks and costs for a rapid review versus systematic review. And we will be comparing the feasibility, the timeliness, the comprehensiveness, fit to purpose, and perceived risk of bias from the broad perspectives of our knowledge users for rapid reviews and for systematic reviews. So the whole purpose of doing this was because we would like to be able to go to our knowledge users and say, we could produce results to you within 3 months. However, there is a 25% chance that we may have missed an important study, or that we may have got the results incorrect. So right now we don't really know. And that's why we've decided to do the study, just so that we can all go into this with our eyes open and know what is the impact of perhaps omitting certain steps for the systematic review process, or using some streamlined methods for this. So now I'm going to switch gears a little bit, and I'm going to focus on providing some tips on how to conduct a rapid review. This is mostly based on our guide that we published in collaboration with the World Health Organization. So this was, we had many individuals and collaborators internationally who helped with this. So it definitely was a huge team effort. And the focus of this was trying to strengthen health policy and systems. The most common type of knowledge synthesis is a systematic review. So this is the type of method that most people are familiar with. And so I'm going to start walking us through the systematic review steps at a very high level. And then I'm going to switch gears, and I'm going to talk about how we could potentially tailor those steps when we're thinking about a rapid review. So the systematic review steps are based on the Cochrane Handbook for Systematic Reviews. We would start with our protocol. So we would develop a research question. Often we use the PICO's framework because with the Cochrane Handbook, we're dealing with, for the most part, intervention. So we're doing systematic reviews of interventions. So we often start off with this, and then our eligibility criteria will follow based on our PICO research question. We will work with a librarian to plan a literature search, as well as potentially register our protocol. So we could register it with the Prospero database as an example, and sometimes we may publish our protocol as well. So we work with the librarian to conduct a very comprehensive literature search. We want to search at least 2 databases. We search for unpublished literature or difficult to locate, otherwise known as gray literature. We may hand search key journals, we may ask experts and scan reference lists, and often we get a second librarian to press the lit search. So that's using the peer review of electronic search strategies that was put forth by Dr. Jesse McGowan and colleagues. We conduct our level 1 and level 2 screening. So we do, level 1 is usually titles and abstracts, and level 2 is full text articles. So to do this, we would have a pilot test amongst the team. Then when we have good agreement, we would have one person screen and perhaps another person verify. So perhaps checking the list of excluded ones. And then, or we may have 2 people independently. And we would have any disagreements that have occurred regarding the inclusion or exclusion would be resolved via discussion. A similar process for abstracting the data. So we would pilot the form. We would either have 1 reviewer and 1 verifier, or we would have 2 people abstract data independently, and the conflicts would be resolved often by discussion, or we may involve a 3rd reviewer. The critical appraisal, so this would be focused on the internal validity or risk of bias assessment. So we want to know what is the risk of bias. In particular, when we're thinking about randomized controlled trials, we would use the Cochrane risk of bias tool as an example. And when we do our critical appraisal, again, we will pilot the form amongst the team, make sure everyone agrees, is answering things correctly. Then we would have either 1 person and 1 verifier, or we'd have 2 people do this. We will use tables and text to summarize the study and patient characteristics. And we'll think about synthesizing our results. So what makes the most sense? And again, this would all follow based on our questions. So shall we use a meta-analysis? Should we just do a descriptive summary? Should we conduct a network meta-analysis? Is there a potential for individual patient data meta-analysis or network meta-analysis? And we would also think about, should we use qualitative synthesis methods, or will this be a mixed synthesis where we're mixing qualitative and quantitative data? We will present the results. So we're going to summarize, we're going to contextualize the findings, use summary tables and figures, and we want to make sure that we discuss all the policy, practice, and clinical implications of our results and how our results can be used to inform policy, practice, and clinical decision-making. So this is the high-level systematic review process in a 2-minute time span. So I think many of us are very comfortable with these steps and very comfortable with this process. So now moving on to the rapid review and thinking about this. So this again is based on our WHO guide that I mentioned previously. So we want to start with our protocol, and if it's a rapid review of interventions, then we would often use PICO as a nice framework to conceptualize our research question. We will plan the literature search. We can register our protocol, and we recommend that we do that. However, we don't have time to publish the protocol because the rapid review is going to, by the time the protocol is published, the rapid review will be done. However, it is good for us to register it and take the time to do that. So we want to search still at least 2 databases just to make sure that we're picking up all the relevant citations. So search 2 databases. However, we might limit, so for example, for the systematic review, maybe we search 5 databases, but for the rapid review, we would only search 2. Sometimes we may not conduct an extensive search for gray literature, and sometimes we may even restrict it by the date of publication as an example to make sure that we have the most recent literature and to try to think about how can we reduce the scope to produce rapid results. And when we're working with our knowledge user, we can actually engage with them at every single one of these steps. So we talk with them at the protocol and level, and we ask them, what's your question, what's your decision, what's your time, and make a whole plan around that. We send them the protocol for their approval. We often ask them for potentially relevant studies that they're aware of to help build our literature search on. And we also send them the terms to make the literature search terms to make sure that they agree. So regardless of if this is a rapid review or a systematic review, we recommend searching at least 2 databases, and we recommend that you work with a librarian to do your rapid review literature search, and we also recommend using the PRESS checklist. So we have level 1 and level 2 screening. So for this, what we might do is we may have just one person screen everything, or we have the one person screening and another person is going to look through the list of excludes as an example. So that would be a little streamlined step, and we would work with our knowledge user at the screening level and saying, we found this study, we're not sure if it's included, what do you think, would it be helpful for you or not helpful? So again, we have this constant communication with our knowledge user throughout. Then when we move on to abstracting the data, the same kind of thing, we might have some of the data points to be abstracted by 2 people, or some of the data points to be abstracted by 1 person and 1 verifier, and the rest to be abstracted by 1 person. So this is where we're thinking about how much time do we have, when do we need the results by, and sometimes if we're planning to do a meta-analysis with the rapid review, which is not common, but it can be done, then maybe for those outcomes that we're planning some more formal analysis on, those would be the ones that we would have 2 people do the full data abstraction on independently. And for critical appraisal or risk of bias, we would prioritize the assessment of key sources. So there might be a couple of items or components that we're most concerned with. So maybe those are the ones we focus on. We may have just one person conduct the risk of bias or critical appraisal. And when we've looked in the literature, many rapid review producers actually skip this step just because of a lack of time. And just to note that I'm not suggesting we skip this step. I think oftentimes the critical appraisal or risk of bias appraisal is very useful to our knowledge users. So again, it would be working with them and seeing what would be most helpful to them. We may limit the number of tables and text used just because of, again, timing to get that report into our knowledge user very quickly. We will limit often to very high level descriptive summary of the studies. Oftentimes with rapid reviews, as I alluded to, we aren't doing a formal evidence synthesis, so we're not doing a meta-analysis or a formal qualitative evidence synthesis, just because of lack of time, and also because we may have taken steps or shortcuts that may make it unreasonable for us to do a meta-analysis as an example. We may provide a more streamlined product, so maybe just like a 1-page summary at the start. We may present a very, short report with mostly tables. Again, working very closely with our knowledge user along the way at every single step here, and asking them, what makes sense and what kind of a product or knowledge product can I provide to you? Asking them these questions at the very beginning. So do you want a slide deck? Do you want a 5-page report? Do you want a 1-page summary? Do you want all of the above? Do you want a webinar? Thinking about all these different things that we can provide to them. And then we want to discuss any potential policy, practice, or clinical implications with caution. So we want to be thoughtful about the streamlined steps or the steps that we've omitted and how this may have impacted our results and our interpretation of results. So now I'm going to move on to how can we tailor our rapid reviews to our knowledge user needs. So in terms of our WHO guide, we recommended that researchers tailor their methods to the needs of knowledge users. And there are several different ways that we can do this that are related to the scope and timeliness across all steps of the review process. So I've kind of covered this, but just thinking this through again. So when we're developing our research question, we want to select which type of review would be the most helpful for our decision makers. And the Knowledge Translation Program has produced a cute little tool called What Review is Right for You. And so it's a simple tool where you can answer a series of questions, and we will tell you which review we think might be most appropriate for the specific topic. I do want to give a shout out to Crystal Amog from my team and others in BAFAM who've been working on this, as well as Dr. Andrew Booth and Dr. Christina Godfrey, who've provided us with a lot of insight and information on this tool. So we work with our knowledge users and decide, what type of a review. We negotiate the timelines with them. So when does your decision need to be made? When can we provide you results? We work with our librarian to plan the literature search, doing a lot of scoping searches, what makes sense, what doesn't make sense, and then registering our protocol. So again, thinking with our knowledge users, so sometimes we ask them, is it okay if we limit it to the last 10 years? For the topic of choice, does this make sense? So if we're doing a rapid review on COVID, then maybe it does. Maybe we, just limit it to the past couple years. And then also thinking about the languages, right? So can we limit this to English? Sometimes we can't because it just does not make sense. We're going to miss very important studies if we limit this to English, which I would argue would be the case for COVID. You want to make sure you include everything because it's an international pandemic, and so we want to make sure everything is there. We may limit the number of databases. So 2, does this make sense? Does it not make sense? Do we need to do an extensive search of gray literature? Is there a likelihood based on this topic that and working with our knowledge users and their knowledge of the literature, because oftentimes they know they've done preliminary searches, this is their content expertise as an example. Is there a way that we can not search the gray literature comprehensively? So what would be some tips for us that we get from insight from our knowledge users? We may use a layered search approach. So we may start off with, looking at systematic reviews, and then if we don't find enough of those, then we go down to primary examples as an example. Or for example, we might start off with guidelines, very high level. If there aren't a lot of guidelines or a lot of information, then we go to systematic reviews. Again, if there's not a lot out there, then we go down to primary studies. So this is a layered approach that we have used in some of our rapid reviews with our knowledge users. And again, it depends on how broad the area is, what would be helpful to them, what wouldn't be helpful to them. Can we limit the study type included? So can we focus on primary studies only, as an example? And oftentimes with our literature search, we're going to prioritize the specificity over sensitivity. So we're not trying to get every single study done under the sun with our rapid review. We want to make sure that we have the bulk of the research there, enough that we can inform their decisions. When we're thinking about screening, again, who is our team? And how experienced are they? Are they going to miss any potentially relevant studies? We use the data from our pilot test to make these decisions. Sometimes we match up a very experienced screener with a less experienced one. Who on the team is making more mistakes? We're not making them wrong for it or blaming them or pointing them out. We're just saying, okay, this is a challenging area for you to screen. That's totally fine. We're going to match you up with someone who is very experienced and make sure that we're doing this well. Or do we have a really senior person who could actually do all the screening themselves? We may also think, can we use semi-automation? Can we use crowdsourcing or online software? And we do have some citations at the end of the presentation that could help provide you some information on semi-automation, crowdsourcing, or online software. And when we're thinking about data abstraction, it's the same kind of idea. Do we have experienced reviewers, less experienced reviewers? Do we have to have 2 people abstract some of the data points? Can we use semi-automation, crowdsourcing, online software? Can we have synchronous data abstraction across teams? Can we have parallelization across tasks? So as studies have been identified as being relevant at level 2 screening, can we have individuals doing data abstraction? So some people on the team are doing screening and some people are doing data abstraction. And the same kind of ideas with the risk of bias appraisal. So we would be thinking through the same things. And when it comes to our synthesis, so we want to limit to a very high level description of the summaries. Sometimes we send preliminary results to our knowledge users and say, okay, what are the key issues and what can we do a deep dive on? We may use summary of findings tables without writing a lot of results or writing a lot in the report, sometimes we just send the tables to the knowledge user if that's what they want. And there could be a dashboard of research as a tool to help automate this. And again, we want to discuss any implications of our results with caution. We may provide a more streamlined product. So when we're thinking about our dissemination, so something like a one-page summary, we can tailor this by working closely and making sure, you know, sometimes we work with our patient partners to write this and make sure that it makes sense and is helpful to patient partners. We would also do this, so we would co-produce these knowledge products with our policymakers as examples or our healthcare providers to make sure that each one-pager is tailored according to their needs. And we may also use alternate mediums to make sure that our message gets out. So it's things such as social media, YouTube, Twitter, LinkedIn, or just going right to the media as well. So I think that we will quickly stop here for a quick poll, Marina.
Yep, that's perfect. So let me check where we are. So if anyone hasn't done poll number 3, I can just see the results here live. So for timelines, it's 25%. For budget, it's 5%. Purpose is 47%. And for scope, that's 23%.
Great, thank you so much. So this is great. I agree, all of these are super important. And I think that, you know, going back to the objective or purpose of the rapid review is super important. So very interesting that about half of you felt that way as well. So that's fantastic. Thanks everyone for your participation. So I'm going to quickly talk about rapid reviews during COVID for the next few minutes. So this is a real life example. So the Public Health Agency of Canada is a knowledge user, and they were interested on the safety and efficacy of all available drug treatments for COVID. They want this information to improve the health of Canadians. And how can we generate this? Well, we can generate this through a rapid review. So we produced a rapid review in 2 weeks. It was a very high level rapid review, and we did post this on a preprint server. And again, we had to be very thoughtful and work closely with them. These are individuals that we have long-standing relationships with. We're collaborating with them on multiple different things. So it does make it easier, but we did have to be very thoughtful about producing results that would be helpful to them. And we also wrote a commentary. So we had about 21 co-authors on this, and a shout out to all of them, including Declan Devane, for all of their help with this. It was fantastic. And what we were thinking about is how challenging it was to do rapid reviews during COVID-19. And some very top high-level solutions. And I'm just going to read out some of the things that I haven't mentioned yet. So one thing would be updating your literature search the same week as a rapid review was publicly available, just because so much literature was amassing so quickly. Another thing that I would say would be using COVID-N. So this is an international collaboration that's being led by doctors David Tovey, Jeremy Grimshaw, and John Lavis. So a fantastic resource, and this can help reduce duplication for rapid reviews. Something else would be to register your deliverables. So actually posting your final report on the Open Science Framework or preprint servers. And then if you are able to do so, consider automating your searching and screening to convert your rapid review into a living review. So would highly recommend folks that are doing rapid reviews during COVID to check out this paper. You know, would be interested to hear if people have different opinions or views on it, or to hear your perspective on it. And hopefully it's useful, and hopefully some of the challenges that we brought up are things that you've gone through. And so the paper is organized in terms of challenges, as well as some potential solutions, as well as some future research endeavors. So now I'm just going to spend a few minutes. I know we're running out of time, and I want to make sure we have a lot of time for all the amazing questions. It looks like a lot of questions are coming in, so that's fantastic. So I want to give some shout outs to others who are doing really important work on rapid reviews. And I don't want people to think that I'm the only person doing work in this area. There are other people, very highly qualified people, who are doing some amazing work in rapid reviews. So a shout out to Dr. Andrew Booth and his colleagues. They created a very useful decision tool for rapid reviews. And so this decision tool covers how do you interact with the review commissioners or knowledge users, as I've been referring to throughout this presentation? How can we understand the evidence base? What kind of thoughtfulness do we need when we're thinking about selecting data abstraction and synthesis methods? And how do we report our rapid review methods? So highly recommend everyone check out their decision tool, which has been very helpful to myself and I know to others in the field. I also want to give a shout out to the Cochrane Rapid Review Methods group, and my conflict of interest is that I am a member of the group, but want to specifically thank Chantal Garrity, who I work very closely with, as well as Adrian Stevens and Valerie King and others for all of your fantastic work. And I know that they've been so helpful when it's come to COVID-19 and have been incredibly active in this space. So wanted to give a shout out to them. And I also wanted to point to some of their very fantastic papers that they've done. So they have one of the citations here is looking at crowd screening. This was a randomized trial. They've also looked at the exclusion of non-English publications, and they've also looked at looking at studies on the methods of rapid reviews. So again, highly recommend folks to check out these results. Also want to highlight work done by my colleagues with the Canadian Agency for Drugs and Technologies in Health and Andrew Booth and others, where they were looking at rapid qualitative evidence synthesis. So this is an area that we touched on in our rapid review guide by Dr. Sandy Oliver in her chapter, which is fantastic. So this was expanded on in here and talking a little bit about this, and unfortunately, they found that there wasn't a lot of methodological guidance when it comes to rapid qualitative evidence synthesis. I also want to give a shout out to Dr. Aurelio Rodriguez, another close colleague of mine who is based out of Spain. And so she's been doing a ton of work on rapid reviews of diagnostic tests. So the work in the presentation I've highlighted today has been focused most on rapid reviews of interventions. However, just want to make everyone aware that there are rapid reviews of diagnostic tests, some methodological advancements. So highly recommend you check this out if you are working in that space. Also want to give a shout out to ESSE, Dr. Declan Devane, Elaine Toomey, Nikita Burks, James Thomas, et al. They are doing a rapid review methodology priority setting partnership using the James Lind Alliance method. So this is quite interesting. And again, my bias is that I am involved with this. So very exciting and trying to prioritize methodological advancement in rapid reviews. So this is something very needed. And I'm just so excited and happy that my colleagues at ESSE are leading this important work. Also want to mention that we are doing a PRISMA extension to rapid reviews. Again, this is being led by Doctors Adrian Stevens and Chantal Garrity, Mona Hersey and David Moore. So this will be coming out, look out for this, and something where we will be using the PRISMA reporting guide, but extending it to rapid reviews and letting everyone know how to modify your reporting when you're dealing with a rapid review, because there are some important nuances that we need to bring up and take into mind. And finally, I want to talk about the Cochrane Qualitative and Implementation Methods Group. So they are meeting the need for qualitative research and synthesis for emergency situations. So they are providing some guidance and illustrative examples, and Dr. Andrew Booth did make me aware of this. So this is something else that I think will be highly important. And I know that folks from ESSE were collaborating on some rapid qualitative evidence synthesis during COVID. So fantastic work and definitely something that we can all learn from. So I'm getting to the end, and Marina told me I need 10 minutes for questions at the end. So I do want to give a huge shout out to my knowledge synthesis team. I am so grateful to all of you, and you make coming to work fun. And you also are such an inspiration coming to work every day, happy. I mean, working from home right now, but you know what I mean. Working from home very happily, always willing to lend a hand and get involved. And this is a very brilliant group of people that I am honored and privileged to work with. And actually, sorry, I should give a huge shout out to Shazia for all of your help with this presentation. You're amazing, and thank you so much. And I also want to give a shout out to our ESSE trainees. So you guys are all fantastic, and I learn something from you all the time. I have monthly meetings with most of you every month, and I don't know what's going on in Ireland, but you guys have like the most talented people. So a huge shout out to all of you. I have some references here, and I know that these are being covered very quickly. So if anyone ever wants to email me or ask for more details about, or for me to send these references, I'm happy to share those. And now I think, Marina, I can take some questions. Thank you so, so much.
Perfect. Andrea, thank you so, so much. That was incredibly insightful. And I can just see now that the flood of compliments coming through is really,